And we have some left out topics in CVS. We will continue to finish those left out topics. Okay? So, what are all the topics we are going to cover? We are going to cover disease. Remember, Kawasaki disease is the most common vasculitis in children. Okay? The most common vasculitis is Kawasaki. Most common vasculitis in children. Second one, vasculitis in children is Kawasaki disease. Remember, it is going to replace acute rheumatic fever as the most common cause for acquired heart disease. Acquired heart disease. Second, when you don't treat Kawasaki, what will happen? It will invariably lead to coronary artery aneurysm. Will invariably lead to coronary artery aneurysm, and it can, this undiagnosed coronary artery aneurysm can lead to death or myocardial infarction in young children. Infarction in young children. So whenever any child between 10 to 20 years die of myocardial infection, always you think in terms of, always you need to think in terms of, think in terms of a Kawasaki disease, right? So what is the presentation? And also, whenever you have vasculitis, it is a multi-system involved. Multi-system, okay, it is a multi-system involved. So how to diagnose Kawasaki? Very, very simple. So this is first point. When you don't treat Kawasaki disease, almost 25% will have coronary artery, and when you treat, only 2 to 5 percentage will have coronary artery. Okay, remind that throat still continue. So how will you diagnose? Remember, it is usually common in children less than 1 year. It can also occur up to 5 years, but most common in children less than 1 year. So when will you suspect and how will you diagnose Kawasaki? So how will you diagnose any infant who is brought with high grade fever of more than 7 sorry 5 days duration? 5 days, high grade fever lasting for more than 5 days duration. Always you need to think about more than 5 days duration. High grade fever lasting for more than 5 days duration in any infant less than one. Think about Kawasaki. But you need to have certain points to say whether it is a Kawasaki. These are, so what are all the points that you need to know? So simple. 5 points you. What are all the 5 points? You all know that Kawasaki disease is a mucocutaneous lymph node syndrome. So mucus means 2 points. Mucus means 2 points. So what are all the 2 points? First one is eye. So it is bilateral, non-purulent. bilateral non-purulent bulbar conjunctivitis. Bulbar conjunctivitis. This is point number 1. Second point is with respect to mouth. Strawberry tongue and strawberry pharynx. So 2 points with respect to mucus. Another 2 points with respect to skin. So what are all the points with respect to skin? So in the first week, you will get diffuse red maculopapular rash. In the second week, you will get periungual desquamation. Periungual desquamation. That is peeling of palms and soles. So 2 points with respect to mucus, 2 points with respect to skin, and 1 point with respect to node. Single cervical lymph node of more than 1.5 cm. So how many points you have? You have 5 points. So bilateral non-purulent conjunctivitis, strawberry tongue, diffuse maculopapular rash, periungual desquamation, and cervical adenopathy. So these are all the 5 points. So what do you mean by complete Kawasaki? So complete Kawasaki disease means one major criteria. Major criteria is fever lasting for more than 5 days in an infant. Plus when you have 4 minor criteria, you are dealing with a case of Kawasaki. Minor criteria is these 5 points. Whereas what is called incomplete Kawasaki? What is called incomplete Kawasaki disease? Incomplete Kawasaki disease is one major, that is fever lasting for more than 5 days in an infant, plus less than 4 minor criteria. 4 minor criteria. This is called as incomplete Kawasaki. Okay, one is complete Kawasaki. Second one is incomplete Kawasaki. Right. So what is the treatment of? So always whenever you suspect Kawasaki disease, you need to take an echo less than 10 days. Ideally 10 days after the onset of this, to find out coronary artery aneurysm. To find out coronary artery aneurysm. To find out coronary artery aneurysm. Right? So, and remember, if it is more than 2 Z scores, the child is prone for coronary artery aneurysm. Okay, more than 2 Z score, so this is called high risk. Okay, now you have diagnosed Kawasaki disease. One is major criteria, another is minor criteria. What is complete Kawasaki? What is incomplete Kawasaki? Echo should be taken by about 10th day to find out whether any coronary artery aneurysm is there or not. And then after this, what you need to do? You need to do treatment. So what is the treatment of choice? Look here. The treatment of choice is the treatment of choice. When you have a coronary vessel, more than 2 Z score, then 3 drugs you need to give. 3 drugs you need to give. So one is 2 gram per kilogram IVIG over 12 hours. 12 hours plus aspirin 50 mg per kg per day till the child becomes afebrile. Plus, so one is IVIG, second one is aspirin. What is new here? Pulse methyl prednisolone at 2 mg per kg per day. Okay, till the child becomes afebrile. Till the child becomes so this is the drug of choice. If complete Kawasaki disease plus but Z score less than 2 means then only aspirin plus IVIG is enough. 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 But when you diagnose Kawasaki, but the child becomes afebrile means there is no role of giving an IVIG or anti-inflammatory high dose aspirin. So when the child becomes afebrile, but coronary artery aneurysms are present means you can give lifelong aspirin. If the aneurysms are huge, you can give aspirin plus clopidogrel. Aspirin plus this is antiplatelet. Antiplatelet dose is 5 mg per kg per day. Sometimes over that aneurysm, the child may have thrombosis, leading to acute infarct. So at that time, you can give thrombolysis. Okay, then people will now started asking, what is resistant Kawasaki disease? So what is resistant Kawasaki disease? So resistant Kawasaki disease means child continues to be febrile even after 36 hours of starting IVIG. It is called as resistant Kawasaki. Okay, what are all the treatment options? The treatment options are rituximab, cyclophosphamide, mycophenolate mofetil, and then infliximab. And then you can try second dose IVIG. So remember, this is called resistant Kawasaki. Remember, my dear friends, 200% you will be having some questions with respect to Kawasaki disease. So please read it. This is more than enough. This 10 minutes is more than enough to complete our Kawasaki. Any infant with high grade fever of then high grade fever of more than 5 days duration along 5 days duration along with raised inflammatory markers like ESR and CRP means always go for echo between 7th to 10th day to look for coronary artery aneurysm. Other clues for Kawasaki. 1. There is reactivation of BCGs. There is reactivation BCG scar. Okay, the size of the BCG scar will suddenly increase. And remember, there is marked irritability of an infant. The infant will be markedly irritable. You can't console the child. Third one is the first one is reactivation of BCGs. Our second one is marked irritability. Third one is in the second week. In the second week, you can have thrombocytosis. Your platelet count will be touching around 7 to 10 lakh. So these are all the indirect clues to diagnose Kawasaki. Okay. So what are all the things you need to know? One major criteria, another minor criteria. So what is the investigation of choice? Echo. Second, what is the treatment option? Second, and then what is called resistant Kawasaki disease? What are all the direct, right? So this is all about Kawasaki. Okay. about Kawasaki disease. So this is very, very important. Kawasaki. So one topic over. The next topic is Pompey's disease. Pompey's disease. We don't see much hypertrophic cardiomyopathy. You know, you have restrictive cardiomyopathy, dilated cardiomyopathy, and hypertrophic cardiomyopathy. As far as 2Gs are concerned with respect to pediatrics, you need to know Pompey's disease. So what is Pompey's disease? Pompey's disease is always you need to read in such a way that how the case is going to come, how the case is going to come clinically. So let me say, so the presentation will be floppy infant. The presentation will be floppy infant. Second, you have a huge cardiomegaly, what we saw in like in Epstein's anomaly, very huge cardiomegaly, wall to wall heart. So huge cardiomegaly, wall to wall. Okay, and then when you take an ECG, you have massive, large QRS complex, massive, large QRS complex, and you have short PR interval. PR. Okay, this is the present. Remember, it comes under type 2 glycogen storage disorder. Type 2 glycogen storage disorder. Okay, comes under type 2. It is due to deficiency of acid maltase. Deficiency of acid. What is the treatment of choice? Enzyme replacement therapy. What is the treatment of choice? Enzyme replacement therapy. That's all about Pompey's disease. So Pompey's disease means draw a large QRS complex and then large a massive heart. This is more than enough for an undergrad. So next, what next? So Pompey's disease. Have then you have what is this? Ventricular tachycardia. SV. So this is the most common tachycardia in infants. Okay, remember how will you diagnose supraventricular tachycardia? So any infant suddenly brought with respiratory distress, and on examining the heart rate is usually between 220 to 240, and your respiratory rate will be high. So now you need to do what? You need to take an ECG. You will see narrow tachycardia. You will see narrow complex tachycardia. So normally you have this is E wave, Q wave, RST. This is normal. Again you have P wave. Again you have P wave, QRST. And you have P wave, QRST. So this is the normal P. Okay, Q R S P Q R. Okay, yes. So this is the general. So what happens in case of SVT, supraventricular tachycardia? Here what will happen? Absent P waves and narrow QRS. Narrow QRS. So what will happen? You have this. Look at this. So you have narrow QRS complex. Let me show you the ECG itself. So absent P waves and narrow QRS complex. means it is supraventricular tachycardia. Unless otherwise proved, it is supra. I have not drawn a narrow QRS complex. A narrow QRS complex means less than 2 small. Okay, so you will have like this. So this is typical. Okay, this is typical supraventricular tachycardia. Okay, narrow QRS complex and heart rate is increased. So what is the treatment of? Now you need to go for what is the treatment of. The treatment of choice is whether you have dealing with a stable patient or unstable. Unstable patient means the child is in shock. Then you don't have any time to act. So you need to give direct cardio version. You need to give direct cardio. That is the treatment of choice for unstable patients. For stable patients, the drug of choice is intravenous adenosine. It causes AV node refractoriness. Node refractoriness. IV adenosine. 2 doses of IV adenosine can be. 2 doses of adenosine. And remember, adenosine has a very short. So you need to give into the line which is as close to the neck as possible, as close to the heart as possible. So the line should be as close to the heart as possible. Okay. So adenosine is the T. Sir, if adenosine is resistant, then you can give amiodarone decanate. And always you need to put the patient on long-term, okay, beta block. Long-term beta blocker or digoxin can be. But here there is a caveat. Because the child is prone for recurrent, the child is prone for recurrent SVT again and again. So what is the long-term treatment for supraventricular tach? So now you have whether you need to ask whether WPW syndrome is present or not. You need to ask whether WPW syndrome present, absent. When there is no underlying WPW, you can give either digoxin or you can give propranolol. But when WPW syndrome is present, when you give digoxin, the child will have further supraventricular tachycardia. So WPW syndrome absent means digoxin and propranolol. If it is present means only beta blocker or propranolol can be. Propranolol can be given. That's it. So this is SV. Very, 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 very important. So when so look at this. Let me show you one thing. Wait. Okay. So supraventricular tachycardia. Pompe's disease, resistant Kawasaki, SVT. So what are all the points that you need to know? Any child is brought with respiratory distress with a heart rate of more than 220 to 250 per minute along with the tachypnea. You need to take an ECG to look for absent P waves and narrow QRS. When the heart rate is more than 220 per minute along with absent P waves and narrow QRS complex, then you need to find out whether the child is in shock or not. When the child is in shock, you need to go for direct cardioversion. When the child is not in shock, adenosine can be. Adenosine, it should be given into the vein which is as close to the heart as possible because it gets inactivated in the blood even before it reaches the heart. So 2 doses of adenosine can be tried. If it doesn't work, you can give amiodarone, you can give flecainide. Right? Long-term therapy with WPW, without WPW. With WPW means only beta blocker. Without WPW means either beta blocker or digoxin. Never ever give verapamil in infants. They are prone for, that point was missed. Don't give verapamil in children, particularly less than 1 year, because they are prone to produce congestive cardiac failure. They are prone to produce congestive cardiac failure, right? Congestive cardiac failure. Okay. Now, now let's speak about acute rheumatic fever. Let's speak about rheumatic. You all know that what are all the points in acute rheumatic fever. You all know whenever any child, you have major criteria: arthritis, carditis, chorea, and arthritis, carditis, chorea, subcutaneous nodules, and then skin lesion called erythema margin. This is major criteria. Arthritis, usually large joint, migratory arthritis, and you will have dramatic response to aspirin. You have dramatic response to, okay, carditis is always pancarditis. You have acute mitral regurgitant murmur. Acute is mitral regurgitant murmur. Chorea late manifest, particularly occurs in girls. Subcutaneous nodules directly proportional to carditis. More the subcutaneous nodules, more the carditis. Erythema margination is also a rare manifestation. What are all the minor criteria? Minor criteria is, so arthritis is migratory polyarthritis. What are all the minor criteria? Minor criteria is fever, arthralgia, elevated ESR, elevated CRP. Okay, fever, arthralgia, elevated ESR, elevated CRP. Okay, CRP, and then prolonged PR interval. In easy, you will get prolonged PR interval. These are all the minor criteria. So these are all the minor criteria. Minor criteria. But what is new with respect to acute rheumatic fever? What is new in Jones criteria? What is new in Jones criteria? At present, they had divided into, the population of the world is divided into high risk and low risk. High risk and low risk. What do you mean by high risk? When you have more than 1 per 1,000 acute rheumatic fever in a year, it is called per 1 per 1,000 population. Acute rheumatic fever is called as high risk, or more than 1.5 per lakh of rheumatic heart disease means high risk. Low risk means less than 1 in 1,000 of acute rheumatic fever, or less than 1 in 1.5 per lakh of rheumatic heart disease means low risk. Means low risk. So why what is the use? So far we are utilizing the old Jones criteria that is meant for low risk criteria. But in a country like India, where streptococcal group A beta hemolytic streptococcal Sore throat is so common. If you don't treat properly, what will happen? It will lead to more and more rheumatic heart disease. Okay, you all know that group A beta hemolytic streptococci is the most common cause, and the treatment of choice is amoxicillin. And the recent guidelines is that you can give 50 mg per kg per night, only one dose, maximum 1000 grams for about 10 days. For about 10 days. Okay, for about 10 days, and it should be started within 9 days of the onset of fever. So that is the new guidelines. So based on the new guidelines, what are all the changes? Look here. Previously, we used to say major criteria. So we are speaking about old criteria. Old criteria is carditis. In new criteria, the same carditis. We don't have any change. In old criteria, only polyarthritis should be considered as a criteria for rheumatic fever. Look at this, polyarthritis. But it is not polyarthritis now, even monoarthritis for arthralgia. Previously, arthralgia comes under minor criteria. Here, polyarthralgia comes under major criteria. Very, 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 very important. Monoarthritis, a major criteria. Polyarthralgia is a major criteria. Okay, right. And then with respect to chorea, no change. Erythema marginatum, no change. Subcutaneous nodule, no change. So the change with respect to very, very important for your NEET are next are aims or INICET. Okay. And previously polyarthralgia comes under minor criteria. Now polyarthralgia comes under major criteria. Previously we don't include monoarthralgia under any criteria. But in high risk cases, monoarthralgia becomes a minor criteria. Previously, fever of more than 38.5 degrees Celsius is considered. But even at present, fever of more than 38.5 is considered. But right now, the threshold has been reduced to 38. It is not 38.5, it is 38. Previously, ESR of more than 60, but now ESR of more than 30. Previously CRP of more than 3, now also CRP of more than 3. So what are all the new changes? This will be asked in your Vivavos. So what are all the new changes? The new changes are 1. ESR from 60 it has been reduced to 30. Fever minor criteria it has been reduced from 38.5 degrees Celsius to 38 degrees Celsius. 3. Previously mono arthralgia not a criteria, now it is a minor criteria in high risk group. Previously polyarthralgia comes under minor criteria, now it comes under major criteria. Previously monoarthritis doesn't included, now monoarthritis is included under major criteria itself. Monoarthralgia comes under minor criteria. Monoarthralgia comes under minor criteria at present. Previously we don't consider at all. So this is with respect to high risk population. This is very, 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 very important. What are all the differences between old and new criteria? Old and new criteria. Differences between old and new criteria. Right? That's all. Okay. So I'm not going to deal in detail about acute rheumatic fever. It is not going to solve the purpose. The purpose is to know the difference between new and old Eckert-Jones criteria with respect to rheumatic fever. Right? Then Finally, what is the and one more thing that I left out in supraventricular tachycardia is in the treatment I missed. I'm sorry. So we don't carotid massage. We don't do in pediatrics. We don't do in pediatrics. The only thing that we do in pediatrics is cold massage over face. In grown-up children, you can use Valsalva manual. And also pressure over eyeballs. In pressure over eyeballs, we don't practice to terminate SVT in case of pediatric. Okay, right. And finally, the last point to discuss and the last point before that I would like to conclude is, okay, Duke's criteria. Duke's criteria is meant mainly for what? Duke's criteria is meant mainly for infective endocarditis. Any child with rheumatic heart disease, established rheumatic heart disease, when present with fever without URI is equal to infective endocarditis. Endocarditis. Very, very important. Okay, the most common native valve is involved with respect to Staph aureus. Native valve. When you have a diseased valve, it is usually Streptococcus viridans, mitis, mutans, sanguis. When you have an IV drug users, you can have Staph epidermidis. When you develop infective endocarditis after surgery, open heart surgery, always it is fungal endocarditis. Almost it is fungal endocarditis. Okay, that's all. Okay, so what are all the criteria? The criteria is, remember, you need to have two positive blood culture. You need to have two positive blood cultures to say whether it is what is the, because you can plan treatment based on the organism that is grown. So you need to have two positive blood culture. Remember, two separate cultures as usual. And if you suspect other unusual organisms, two more can be required. Always you need to take an echo periodically to look for whether any vegetations are present or not. So a major criteria includes positive blood culture as well as evidence of infective endocarditis in echo. Whereas minor criteria, what are all the minor criteria? Minor criteria. So as I told you already, when any child brought with fever in the background of established rheumatic heart disease, in the absence of cold and cough, is infective endocarditis unless otherwise proved. Predisposing condition most common is VST. With respect to acyanotic, with respect to cyanotic, tetralogy of Fallon. Okay, embolic manifestations, immune complex phenomenons. Okay, peticulae, purpurae, so many things. When you have single positive blood culture, echo findings are there but not meeting the criteria means, think about, they comes under minor criteria rather than major. You need to have two major or one major or three minor or five minor required for diagnosis. Five, one major or one major plus three minor or five minor is required for diagnosis to suspect infective endocarditis based on Duke's criteria. Any child who is brought with low grade fever along with new onset clubbing, usually it takes more than 2 weeks. New onset clubbing splenomegaly, splinter hemorrhages, petechiae. Always inflammatory markers will be high, very high, and microscopic hematuria also is an investigation of choice for infective endocarditis, or these due to embolic phenomena. Okay, right. So presence of central non-feeding lines. When you have some other lines, in order to give some IV antibiotic or something to the child, it acts as a risk factor because staph epidermidis can cause this through these through those infected lines. So this is about Duke's criteria. So today in cardiology we had discussed the following things. So what are all the following things we had discussed in cardiology? One, uh, what are all the things we have discussed about Kawasaki disease? Two, we had discussed about supraventricular tachycardia. Three, we had discussed about pompous. Okay, so what else we had discussed? New things in what is new in Jones criteria, and we have discussed only some points in Duke's criteria. Okay, and finally, last but not least, we are supposed to discuss coarctation of aorta. Okay, so we'll finish with this coarctation of aorta. Remember, I'm sorry. So what do you mean by coarctation of aorta? So remember, you have, this is your heart, so arch of aorta, and then in the descending aorta, one area will be very narrower. This is called coarctation of aorta. So what will be the presentation of coarctation of aorta? Coarctation of aorta. What is the presentation of coarctation of aorta? So it can present in infants as shock, or it can present as CCF, or it can present as upper limb hypertension, or it can present as upper limb hypertension. Shock, CCF, or else it can present as upper limb hypertension. Okay, right. So what is the clue? Brachials on right side, left side present, but femorals will be weak. Femorals will be weak. So this is the second clue. So any child who is present on day 2 or day 3 with shock, with weak femorals, it is coarctation of aorta unless otherwise proved. Okay, unless otherwise proved. Okay, what is the treatment of choice? It is surgical excision of the affected segment and end-to-end anastomosis. End-to-end anastomosis. Okay, along with end-to-end anastomosis is the treatment of choice. The child can go for recoarctation. For recoarctation after surgery, you can try balloon dilatation. Yeah, for recoarctation, you can try balloon dilatation. Right. So what are all the other things they will ask you? Okay, the other things that they can ask you is, by about 10 years, remember, so this area is blocked. So what will happen? The intercostal arteries will be enlarged to bypass the obstruction. These intercostal arteries will impinge on the inferior border of the ribs, leading to what? Inferior rib notching. Leading to what? Inferior rib notching. Notching. You can see in the X-ray itself, notching of the lower border of the ribs because of the dilated intercostal arteries to bypass the obstruction. 7. In barium swallow. Remember, so this is pre-coarctation. This is the coarctation. This is post-coarctation. You have a, because of this obstruction, you have you have dilatation of the precoactation and post-stenotic dilatation. So this will impinge on the esophagus, on the esophagus. So you have esophagus here. So this is your dilated pre-stenotic and dilated post-stenotic segment. You have esophagus near to the aorta. So when you in barium swallow, what will happen? Okay. So in barium swallow, what will happen? You will have a reverse E sign. Reverse E sign. Because this E sign in barium swallow, because of the impingement of the dilated pre-stenotic and post-stenotic coactation over the esophagus, leading to E sign. Leading to E sign. Right? And you can, because of this coactation, whenever blood follows through the narrowed segment, you can have late systolic murmur. Late systolic murmur in the inferior border of scapula. Inferior border of scapula. Late systolic murmur in the inferior border of the, okay, you can hear in this area inferior, that is a diagnostic clue, right? So again, what are all the other things that you need to know about coactation of aorta? One second. So usually it is just a ductal, that is the coactation segment is after the insertion of the ductus arteriosus. As I already told you, high upper blood pressure in the upper limb is more compared to blood pressure in the lower limb. Older children often presents with claudication like that you get in aortic stenosis. Because of the coactation, you will get left ventricular hypertrophy leading to heaving apical impulse. And you can have suprasternal thrill over the suprasternal notch. As I told you, late systolic murmur in the inferior border of the angle of the scapula. Notching of the inferior border of the rib usually occurs by about 10 years. Because of the forward obstruction, you will get left ventricular hypertrophy. And remember, very, very important. Most common associated anomaly is bicuspid aortic valve. Barium swallow revealed E sign because of the pre-stenotic and post-stenotic dilatation of the aorta over the esophagus. Remember, in many drug-dependent lesion, for example, in coactation of aorta, whenever any child presents with shock, you can use prostaglandin E1 analog alprostadil. Why? Because when a child is present with shock because of severe coactation, when you give prostaglandin E1 analog, the blood will be diverted from the pre-stenotic segment across the aorta into the pulmonary artery, so that it will be helpful to reach the other parts through the intercostal arteries. PGE1 can be used. Timing of surgery: once you diagnose coactation of aorta, immediately you need to do surgery. Restenosis means you can do balloon dilatation. You can do balloon dilatation. Okay. So far we had discussed in detail about cardiology. So far we had discussed in detail about cardiology, right? Okay. So let's it is very, very, very finding it very difficult to control. Alright, so cardiology, yesterday part 1, today is part 2 over. So let me convert this into PDF first and I'll share. One second. One second. I'm sharing that annotated PDF. Right, shared. So part 2 CVS over. Okay, now let's go to Respiratory System. Part 2 series CVS has been okay. Now let's go to now let me start. The CVS is over. Now let me start RS. Now respiratory system. What are all the things that you need to know in respiratory system? 1. Respiratory voices. Okay. 2. TB. 3. Group. 4. Epiglottitis. Glottitis. 4. 5. Cystic fibrosis. 6. Primary ciliary dyskinesia. 7. Bronchiolitis. Okay, these are all the things that we are going to discuss right now. Okay, let's start. So first is respiratory noise. First is respiratory noise. Okay. Okay. What are all the respiratory noise? Okay. Topic is respiratory. Whether it is what are the whether it is inspiratory or expiratory. What is the cause? That's all. The first sound is this is called stutter. This is called stutter. It is inspiratory and it occurs due to secretions in. The second is so what is this? This is called snoring. Snoring. It is again inspiratory. Okay, it is due to adenoid in nasopharynx. In nasopharynx. Third one is what is this? This is called stridor. Stridor is again inspiratory. It is due to more often it is due to laryngomalacia. These are all inspiratory noise. Whereas this is an expiratory noise due to expiratory airway obstruction. Respiratory airway obstruction. At the level of bronchus, usually it occurs in asthma. And then finally you have grunting. Grunting again is an expiratory component. Usually it occurs in pneumonia. Due to partially closed glottis. Partially closed glottis. Due to partially closed glottis, which are due to partially closed glottis. Okay, pneumonia due to partially closed glottis occurs in where pneumonia. Okay, so these are all the respiratory noise. Stutter, snoring, stridor, inspiratory noise, whereas wheeze and grunting are expiratory noise. This is very, very important. Okay, so this is concept number one. Second, when will you suspect group? When will you suspect? What is the other name for group? Acute, acute, laryngo, tracheo, bronchitis. Any virus can. Remember, any virus. But as for your adeno, your corona, any virus can. But for you in exam, para influenza you need to say para influenza you need to say, right? So what is the manifestation? You have edema of larynx, trachea, edema and inflammation and bronch, leading to what? Leading to metallic cough along with biphasic stridor. Along with biphasic stridor. Because of the involvement of subglottic area. Because of the involvement of subglottic area, you will get biphasic stridor. So what is the you people used to say? It is purely a clinical. It is purely a clinical diagnosis. Then you will be asking what is the role of people sign. Role of people sign. That means whenever you take an X-ray neck, you will find the narrowed subglottic area. It is neither sensitive nor specific. So what does it mean nor specific? What does it mean? Can be absent in established group. It can be present in patients who doesn't have any group. People say. So it is a clinical decision. So always when you have doubt, ENT examination should be done in theater with the help of an anesthetist. Why? Because they can suddenly go for laryngoscopy. It can go for laryngoscopy. What is the treatment of choice? All children should receive steroids. Steroids. Either it is dexamethasone or nebulized budesonide. Anything can be given, but all cases should receive either inhaled corticosteroids or dexamethasone or even oral prednisone to reduce the edema. And the cases often require severe cases often require adrenaline nebulization. Adrenaline which causes constriction of precapillary sphincter. Vasoconstriction of precapillary sphincter, thereby reducing edema. No role of antibiotic. No role of antibiotic. So this is what group. Okay. Then comes epiglottis. Epiglottis. Literally, there is no epiglottitis cases at present. We don't see any epiglottitis cases. Why? The answer is very simple. Because of pentavalent vaccine that the government is giving. Pentavalent vaccine that includes hip. That includes hip. So there is no epiglottitis at all. If present, what is the manifestation? The manifestation is high grade fever. The child is toxic looking. Is toxic looking child, high grade fever with three D's. D, D, D. What are all the D's? Dysphonia, voice will be gone. Dysphagia, can't swallow, along with drooling of and in X-ray you will get thumb sign because of thickened epiglottis. Because of thickened epiglottis. Epiglottis. So again, this is basically a clinical diagnosis. What is the treatment of choice? One is elective intubation. You need to intubate the child. Elective intubation saves life, followed by injection. So, injection subtract. This is about what? Epiglottitis. That's all. Any child comes with dysphagia, dysphonia, drooling of saliva. Always think in terms of epiglottitis, and you need to take ceftriaxone along with you need to go for elective intubation. Okay, so we have finished respiratory noises, we have finished group, we have finished epiglottitis. Then let's come to bronchiolitis. Let's come to bronchio. So what is bronchiolitis? When you have episode wheeze, when you have first episode wheeze, is called bronchiolitis. Any virus can cause, but for you, first episode is less than 2 years is called as bronchiolitis. Any virus can cause, but for you, RSV, followed by rhinovirus. RSV followed by rhinovirus. So, what is the manifestation? Usually, child will have URI, which gradually progresses to severe cough, and you can have wheeze, and you can have cramps. In X-ray, you have air trapping because of obstruction. You have collapse of lung in X-ray. So what is the treatment? The treatment is three. One, two. Always because of severe respiratory distress, the child on nil per hour because the child is prone for the child is prone for aspiration. The child on nil per oral because the child is on aspirate. It's prone for aspiration. When you give milk, when the child is having respiratory distress, the child is prone for aspiration. NPO. Second one is okay. One is nil per oral. Second one is nil per oral. Second one is always you give oxygen. Always you give oxygen. And then third one is IV fluids. IV. So role of adrenaline, salbutamol. Third one is 3% saline nip. All these nip. Very role. Very. And remember the child is at risk for future. Is there any preventive drug available? Yes. You have palivizumab. shall be. This is monoclonal antibody against, and then this should be given. This should be given once in a month for 3 months. Three during RSVCs, not for all kids, only for child with bronchopulmonary dysplasia, child with congenital. For high risk cases, you give this. And recently we have NIRSI. Recently you have recently we have NIRSI Sumab. This can be given only once because it has got long off. Instead of giving 3 doses, only 1 dose. Nirsisumab. This is also a monoclonal antibody against RSV. This is something. Nirsisumab. Okay, this is about bronchiolitis. Bronchio. Then comes cystic fibrosis. Okay, then comes cystic fibrosis. You all know that there are more than 2000 mutations that can produce cystic fibrosis. But people talk about delta F 508. There are more than 2000 mutations. People will talk about delta F 508 mutation. 508 mutation. Okay, it is autosomal recessive. So most common after consanguineous, father and mother will be carriers. Consanguineous man. Remember, in India, it is common. Don't say it is uncommon. It is common in India. What are all the organs that are mainly affected? One is respiratory system, another is IT, another is pancreas, another is genital urinary system. In respiratory, what are all the manifestations? You all know the most common manifestation is at birth is meconium. Manifestation is meconium. The most common manifestation is meconium. Okay. Manifestation is meconium. Second one is it can produce hemorrhagic disease of newborn due to vitamin K deficiency. Hemorrhagic disease of due to vitamin K deficiency. Okay, it can present with oily stools due to pancreatic insufficiency. It can lead to, because of fatty malabsorption and poor support to the rectum, it can lead to rectal. It can lead to rectal prolapse. Okay, it can lead to rectal prolapse. Hemorrhagic disease of newborn, oily stools, rectal prolapse. Okay, rectal prolapse. Right? What are all the other It can also manifest as distal intestinal obstruction and present with constipation. Intestinal obstruction. They will ask you what are all the manifestations of cystic fibrosis. And remember, you will lose chloride in sweat, as a result of which the manifestations can be low sodium, low chloride, high bicarbonate. Okay, leading to what? hyponatremic, hyponatremic, hypochloremic, metabolic alkalosis, metabolic alka, mimicking barter. That's why it is called pseudo barters. That's why it is called as pseudo barter. Another manifest. What are all very important? Okay, when any child who is brought with severe dehydration, in the absence of vomiting or loose stools in summer in India, float cystic fibrosis. Rule out cystic fibrosis, right? So, what are all the other manifestations? Can lead to recurrent pneumonia. It can lead to, because of thick mucus secretion, it can lead to lung collapse. So, which lobe is usually involved in cystic fibrosis? Can lead to upper lobe bronchitis. Can lead to upper lobe bronchitis. Okay, it can lead to upper lobe bronchitis. Okay, then as I told you already, it can present as neonatal cholestasis. Cholestasis because of, can present as neonatal cholestasis because of bile duct obstruction. Recurrent pancreatitis in case of heterozygous. Recurrent pancreatitis in case of heterozygous. One gene is involved, another gene is normal. Heterozygous. Okay, recurrent pancreatitis. Okay, recurrent pancreatitis. Upper lobe neonatal cholestasis, recurrent pancreatitis. Okay, what are all the other manifestations? Complete absence of bilateral pause. So all males are sterile. So all males are sterile. Okay, so these are all the manifestations of, and remember, because of fat malabsorption, fat soluble vitamins, vitamin K as well as vitamin D will be low, leading to rickets. And finally, because of poor absorption of vitamin E, it can lead to ataxia. So look at this, how many manifestations of cystic fibrosis is there? Almost so many manifestations. So what are all the investigations for cystic fibrosis? What are all the investigations for cystic fibrosis? So the investigations are: 1. Immunoreactive trypsinogen. Immunotrypsinogen. It will be elevated in blood. It is the newborn screening test. It is the newborn screening test. Which one? Immunoreactive trypsinogen. Elevated. This is a newborn screening test for CF even in India. Second. What are all the other things? Sweat chloride test. Sweat chloride. So usually if it is more than 60 millimole per liter, usually it is more than 60 millimole per liter. Okay, it is considered. Less than 30 is said to be negative, whereas 30 to 60 can be considered as positive, provided you have clinical signs and symptoms are suggestive. You need to do two sweat chloride tests to say positive at 1 month apart. At two sweat chloride tests positive at 1 month apart. Okay. And then right now we are relying on, okay, next generation. You have next generation sequencing, that is genetic test, whether it is homozygous or heterozygous. And very rarely in some center nasal potential differ. Nasal potential difference they will see because of the absorption of the chloride. For you, what you need to know, you need to know sweat chloride test. You need to know immunoreactive trypsinogen. You need to know genetics. And finally, what is other nasal potential difference? Cystic fibrosis patients are notorious for two things. One is pseudomonas. One is pseudomonas. One is pseudomonas. Another is Burkholderia cepaci. Burkholderia cepaci. Also, they are prone for methicillin resistant staph aureus and one more bug called stenotrophomonas. Stenotrophomonas. Okay, right. So, what is the treatment? So, one is enzyme replacement therapy. Enzyme replacement. What is that? You know, no lipase. You give to get usually 3000 international units per day per kilogram in 5 divided doses. Each meal should be associated with lipase ingestion. Second, pseudomonas eradication. Second one is pseudomonas eradication. Okay, what are all the drugs that act against two pseudomonas? One is peptas, meropenem. One is peptas, two is meropenem, three is aminoglycosides, fourth cipro and other quinolones, fifth tobamycin, colistin, peptas, mero, aminoglycoside, cipro, tobramycin, colistin, okay, tobramycin, colistin, and then okay, to peptas, meropenem, aminoglycoside, cipro, tobramycin, and then astrione. This is very very important. Drug that acts against pseudomonas is will be asked, and then you need to fat soluble vitamins, fat soluble vitamins 5 times the recommended daily allowance, that is ADE, and then water soluble vitamins. One is fat soluble vitamin, another is water soluble vitamins 2 times the recommended daily allowance. So this is all about cystic fibrosis. Very 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 important question for entrance, NEET, next INICET, or any examination. And then another cause for recurrent bronchitis is primary biliary dyskinesia. ciliary dyskinesia. So what is the problem here? There is a qualitative or quantitative effect in cilia. Effect in cilia. So usually you have one centriole in the middle followed by 9 pairs. There are so many genes. You have mutation in dynin arm, kinesin. There are so many mutations. Okay. You all know that cilia is highly motile. When you have any of these mutations, you will have immotile. You have immotile cilia leading to what? Leading to what? Immotile cilia leading to what? Middle and lower lobe bronchiectasis. Middle and lower lobe bronchiectasis. Middle and lower lobe bronchiectasis. Okay. Other things, ear discharge is very common. Chronic suppurative otitis media is very common. And then chronic sinusitis is very common. Okay, chronic suppurative otitis media, chronic sinusitis, middle or lower lobe bronchiectasis, very common. Okay, right. So other things, you all know that situs inversus totalis. Situs inversus totalis is also common. Situs inversus totalis is almost occurs in 50% of primary ciliary dyskinesia cases. Okay, so middle lobe atoria, rhinorrhea, lower lobe and middle lobe bronchitis, situs inversus totalis, right? So what is the screening test for primary ciliary dyskinesia? Screening test is nasal nitric oxide. Test is nasal nitric oxide level. It will be low, less than 70 parts per billion. Another is of cilia, and then you can use genetics to look for involved mutant, and then you can identify the structure of cilia with transmission electron microscope. Electron microscope. Electron microscopy to look for that altered structures. So again, supportive therapy, supportive vaccination, just physiotherapy, just physiotherapy. So this is all about cystic primary ciliary dyskinesia. So finally, let's talk about tuberculosis. Let's start about tuberculosis. Okay. You all know in India, it is very common to have tuberculosis. In tuberculosis, you have indirect test and then direct test. So what are all the indirect tests? Indirect test detects infection, not disease. Detects infection. Tuberculosis. So what are all the tests? One is Manto, another is IGRA, another is CTB test. So these are all the indirect. So what about Manto? What about Manto? Okay, you give 2 tuberculin unit intradermally 0.1 ml in the left forearm, and you will ask the patient to come 48 to 72 hours later, and you will find the induration, an induration of more than 10 millimeter is considered as positive, that the child is infected with mycobacterium tuberculosis. Doesn't mean that this is infected. So you can have, for HIV patient, more than 5 millimeter is said to be positive. So what is the drawback for Mantoux test? It can have false positive. False positive means what? ECG can produce false positive. Atypical mycobacterial infections can produce false positive, whereas false negative is common in one, disseminated TB, miliary TB, and then your post pertussis immunodeficiency, such as severe combined immunity. In these children, they'll have false negative Mantoux. Even though the child is infected, you will get negative, no induration. So, Mantoux neither confirms nor rules out an underlying infection. It is a economical test to find out infection, but it is not specific. Not specific. So now, what is not specific? Second test is IGRA. IGRA. What is mean by IGRA? IGRA means you are measuring the interferon gamma released by the macrophages. Where in Mantoux you have identified the macrophage that is occupying the induration area. In IGRA, you will find out the amount of interferon gamma produced by these macrophages. So it is the only blood test used in TB. It is costly. It is specific. Why it is specific? So, and it is one time procedure. Why it is specific? Because you use TB specific antigens, such as TB specific antigen. So what are all the TB specific antigen? So there are some TB ESAT, CFP. These are TB specific antigen. They will take your blood, which is sensitized for an underlying mycobacterial infection if it is present, and the blood is subjected to interact with this TB specific antigen, and they will measure the interferon gamma. So this is specific for TB but costly. The third test is CTB test. C stands for Copenhagen. C stands for Copenhagen. In this, it is a skin test. Instead of purified protein derivative used in Mantoux, they use that ESAT protein. So they will measure the same induration like Mantoux, but an induration of more than 5 millimeter is considered as positive. It is economical like Mantoux, and at the same time it is specific. This is called CTB test, the future test of choice to find out the infection. C stands for Copenhagen. Okay, right. These are all the indirect tests. Now let's go to direct test. Direct TB test. So what are all the tests? One is using smear. So what are all the tests that uses smear? One is you look for AFP smear using Zeal-Nielsen technique. Another is using the same and you will use LED microscope. But this is not sensitive because you need to have 10,000 bacilli per ml to have positive. So we don't use. Second one is second one is okay. Second one is culture. In culture you have two. One is solid culture using LJ medium, Lowenstein-Jensen medium. It take almost 2 months for the result to come. So we don't use. Right now we use something called liquid medium using Middlebrook medium which enhances fast growth and it is optimized to find out the bacilli with the help of an immunofluorescence technique and this is called MGIT. What is called MGIT? MGIT means Mycobacterium growth inhibitor tube system. Mycobacterial growth indicator tube system. So one is smear, second one is culture, third one is smear, second one is culture. So this is very important. MGIT is the gold standard test. Third one is PCR based test. So what are all the PCR based tests? Again this is divided into two. One is CB naught, another is true naught. NAT means nucleic acid amplification test. Okay, this CB naught will detect 160 bacilli per ml. So it is highly sensitive and it detects rifampicin resistance genes. And also the results will be available within 2 hours. Available within 2 hours. The second test is LPA. What is LPA? Line probe assay. So this is line probe assay. In line probe assay detects okay resistance genes for INH, rifampicin, aminoglycosides and quinolone. But it takes 2 days. Okay, now summary. Point of care test is point of care test for diagnosis is sputum or any sample CB naught or true naught. CB naught is American version, true naught is Indian version. Point of care. Gold standard is gold standard is that I told you MGIT. To find out the resistance pattern, what you use is line probe assay. This is the summary. This is the summary. Okay, and fine. And then, what are all the X-ray findings in X-ray findings suggestive of TB? So, what are all the X-ray findings suggestive of TB? Not all cases. Three things. One, when you have hilar adenopathy, When you have miliary pattern, when you have cavity, these are all the X-ray findings typical of TB. Now, what is the algorithm? Algorithm for pulmonary TB, let me tell you. Pulmonary TB. When you have fever, uh, persistent fever more than 2 weeks, persistent cough more than 2 weeks, 2 weeks, along with contact who took ATT TB tablet for pulmonary TB in the past 2 years, and weight loss. Weight loss is 5% in the past 3 months. This is the TB index. When you have such case, you need to take X-ray chest. In X-ray chest, if you find either miliary cavity or hilar adenopathy, you need to do CB naught. Either you can use sputum or gastric lavage. One is sputum, another is gastric lavage, another is induced sputum, or you can take bronchoscopic lavage. So if identified, it is called microbiologically confirmed TB. Confirmed TB. If X-ray is not suggestive, you need to give a course of antibiotics, but you should not include levoflox and linezol. You should not include, should be avoided in that regimen, because this comes under TB, anti-TB. When you give these drugs for pneumonia without knowing that it is TB, you can't retrieve the sample which can show positivity for Mycobacterium tuberculosis, and then give for antibiotic for 7 to 10 days. Okay, if it resolves, TB unlikely. If it doesn't resolve, you need to go for Manto or IGRA. If it is positive, you can to CB. Okay, CB naught. CB naught positive means you will say microbiologically confirmed TB. TB not negative, still you think it is TB, means it is called clinically diagnosed. This is TB algorithm. Okay, algorithm. So what is the treatment? The treatment is 2 months of HRZT daily plus 4 months of HRE, isoniazid rifampicin ethambutol. No role for extending IP. No role for extending intensive phase. You need to rule out when the child is not showing any response, it means it is resistant TB. But CP can be extended for up to 10 months. Up to 10 months in case of neurotuberculosis, in case of neurotuberculosis, in case of one bone and joint TB and neurotuberculosis, you can extend the regimen. We don't have cat 1, cat 2, cat 3 and drug sensitive TB. DSTB regimen. So what are all the drugs for? So when you have resistant to INH, you can give LRZE for 9 months. H should be replaced by levofloxacin. And finally, what are DRTB drugs? You have group which includes linezolid, levofloxacin, and then bidacul. And then group 2 drugs. You have clofazimine and then cycloserine. And then you have group 3 drug. You have group 3. What are group 3 drugs? Para-amino benzoic acid, PABA, triacetazone, amoxiclav is not included right now. You have meropenem. You have imipenem, ethionamide. These are all group 3 drugs. In case of DRTB, you need to give 3 drugs from group 1, 2 drugs from group 2. If it is not possible, plus or minus from group 3. Group 3. Okay, group 3. So what is MDR-TB? MDR-TB is resistant to H and R. What is XDR-TB? Resistant to H or either aminoglycosides or, I'm sorry, XDR-T, pre-XDR, resistant to HR, either aminoglycosides or levofloxacin. XDR-TB, resistant to R, okay, levofloxacin, okay, levofloxacin. And then extremely drug resistance means resistant to R, levofloxacin and bida. Okay, so I think with this I am finishing RS. Thanks for your patient listening, and let me send the PDF format with annotation. Thanks for your patience.